perform the Allen test, occlude both the ulnar and radial arteries. Instruct the patient to make a fist to drain the blood from the hand. This should be done for approximately 30 seconds. Instruct the patient to unclench the fist. The patient's palm should appear blanched or pale. Now release pressure only from the ulnar artery. Adequate collateral circulation is indicated by the return of normal color within 10 seconds. Wash your hands according to good standards prior to examining the patient. Extend the patient's wrist to bring the radial artery close to a more superficial position. The radial artery is located between the styloid process of the radius and the flexor carpi radialis tendon. First, palpate the styloid process of the radius. Next, palpate the flexor carpi radialis tendon located medial to the styloid process of the radius. Now locate the artery between these 2 points. The artery may be difficult to palpate, for example, in the presence of overlying edema or vasospasm. Extend the patient's wrist and place a rolled towel under it to maintain it in an extended position. Once the patient's wrist is positioned, put on a non-sterile gown and non-sterile gloves. Open the arterial blood gas kit and identify all the components so they are ready for use. Clean the site with an alcohol swab. Palpate the radial pulse and determine the point of maximum impulse, or use the Doppler ultrasound device to identify the location of the radial artery. Using the 5 cc syringe and small needle, draw up 1% lidocaine. Upon introducing the needle under the skin, draw back on the plunger to ensure that you have not punctured a vessel. Inject a small wheal of analgesic around the artery and wait 30 to 60 seconds for the lidocaine to take effect. Again, locate the maximum impulse with the index and middle fingers of the non-dominant hand. Holding the arterial blood gas syringe with the dominant hand, aim the needle away from the hand and toward the upper arm, and puncture the skin at a 30 to 45 degree angle at a point just below the index and middle fingers of the non-dominant hand. Advance the needle slowly until the syringe easily and passively fills with bright red pulsating blood. Ideally, you should obtain at least 1 to 2 cc's of blood. If no blood is obtained, do not pull back on the plunger. Withdraw the needle slowly until it is just under the skin and reattempt the procedure. After the blood sample is collected, withdraw the syringe and have an assistant apply pressure to the site with sterile gauze for approximately 5 minutes. In the meantime, expel the air bubbles from the syringe. Cover the needle with the attached safety cap and remove the needle from the syringe. Or remove the needle from the syringe using the rubber stopper. Attach the heparin-containing cap and, while holding the cap in place, push the plunger of the syringe to ensure the blood encounters the heparin. This will prevent the blood from clotting. Ensure that the syringe is labeled with the patient's name and unit number. Place the entire syringe in the bag of ice if transport to the lab is required. After pressure has been applied to the puncture site for 5 minutes, affix the gauze with some tape. Dispose of all sharps in the designated sharps containers. The most common technical difficulty associated with radial arterial puncture for arterial blood gas analysis is failure to obtain a blood sample because of vasospasm, or obtaining venous instead of arterial blood. If vasospasm is suspected, abort the procedure and reattempt it on the other wrist. A blood sample is likely to be venous if it is non-pulsatile and dark in color and it flows slowly. It should be noted, however, that very deoxygenated blood in a patient with hypoxemia could also appear dark, even though it is arterial. Serious vascular complications of radial arterial puncture are rare and include radial arterial aneurysm, hand ischemia, and hematoma causing compartment syndrome.